Dear students, we would go ahead with a very interesting topic, that is about the ulnar nerve. Ulnar nerve is often referred to as a nerve for musicians. It is a musician's nerve or nerve of fine movements because it innervates most of the intrinsic muscles of the hand that are involved in fine, intricate hand movements and are required by the musicians while playing musical instruments. So here is the picture of brachial plexus where we are going to see the origin and its root value of ulnar nerve. So the root value of brachial plexus begins with C5, C6, C7, C8 and T1. And finally brachial plexus will form cords and cords will divide into branches. So there are three cords. This is the lateral cord. This is posterior one, posterior cord, this one, and the down one, this is the medial cord of brachial plexus. So it is one of the thicker branches. You can see here, this is ulnar nerve. So the ulnar nerve, it is a branch of medial cord of brachial plexus. So the medial cord has the root value of C8T1. So ventral rami of C8T1. And ulnar nerve receives a contribution from the ventral ramus, that is from the C7 also, ventral ramus of C7. The C7 fibers in the ulnar nerve supply flexor carpi ulnaris. So the root value is C7, C8, T1. Ventral rami of C7, C8, T1. C7 is meant to supply flexor carpi ulnaris muscle. Let's see the course, relation and distribution of ulnar nerve at each level. So in the axilla, the nerve lies medial to the third part of axillary artery. So we can see here, this is axillary artery. So it is medial to the axillary artery, means this is the ulnar nerve. So to say actually it is sandwiched between axillary artery and axillary vein. So medial to the axillary artery is axillary vein. So ulnar nerve is sandwiched, it is in between the axillary artery and axillary vein in axilla. Then it enters the arm by crossing the lower border of teres major. Then in arm it runs along with the main neurovascular bundle initially and runs distally along the medial side of the brachial artery. So we can see here, this is the brachial artery. Brachial artery is the continuation of axillary artery. So initially it is medial to the brachial artery and we can see it is piercing the intermuscular septum, that is medial intermuscular septum. After piercing intermuscular septum, from anterior compartment it goes to posterior compartment. And posterior compartment it runs downwards towards the medial epicondyle of humerus. This is medial epicondyle of humerus. So at the medial epicondyle of humerus, it is lodged in a groove. Posterior to the medial epicondyle there is a groove and where the ulnar nerve can be easily palpated. And the groove is converted into a tunnel called as cubital tunnel by a fibrous band extending between the medial epicondyle and olecranon process. So I'll draw a little schematic diagram. So this is the medial epicondyle and here is the lateral epicondyle of humerus. So this is the olecranon process of ulna. And this is the posterior view of elbow joint. So here this part is connected by a ligament here, which is a fibrous band turning into a groove or a tunnel. So within the groove or a tunnel, the ulnar nerve is present. So this is our ulnar nerve. So that is about the cubital tunnel. So the ulnar nerve crosses the ulnar collateral ligament in the floor of this tunnel, and ulnar nerve behind the medial epicondyle of humerus because it is related to behind the medial epicondyle of humerus, the humerus is termed as a funny bone. Because when the medial part of the elbow hits a hard surface, a tingling sensation occurs along the ulnar side of the forearm and hand. So this makes to term the humerus as, humor means funny, right? So it is called as a funny bone. So the ulnar nerve does not give any branches in the axilla and the arm. So let's see the ulnar nerve in the forearm. In the forearm, the nerve enters the forearm by passing between the two heads of flexor carpi ulnaris. So this is flexor carpi ulnaris muscle. And in the forearm, it runs vertically downwards between the two heads of flexor carpi ulnaris, and towards under the flexor carpi ulnaris, it runs vertically downwards. So it lies superficial in the lower two-thirds of the arm. It becomes superficial and lies lateral to flexor carpi ulnaris. So this is flexor carpi ulnaris. So it lies lateral to flexor carpi ulnaris muscle. So this is flexor carpi ulnaris. You can see the nerve is here, which lies lateral to flexor carpi ulnaris muscle. In this part of its course, the ulnar nerve and ulnar artery descend together, and the artery being on the lateral side of the nerve. So there will be ulnar artery and ulnar nerve which passes together. And in the forearm, it gives off, like in the proximal part of the forearm, it gives some muscular branches, that is flexor carpi ulnaris, medial half of the flexor digitorum profundus. So to the flexor carpi ulnaris, it gives branches, and also to flexor digitorum profundus, that is the medial half. So only half of the flexor digitorum profundus. These two muscles are supplied by the ulnar nerve in the forearm. In the mid forearm, it gives off palmar cutaneous branch which enters the palm superficial to the flexor retinaculum to provide sensory innervation to the skin over the hypothenar eminence. So this is hypothenar eminence. So palmar cutaneous branch is given in the mid of forearm. This is palmar cutaneous branch, and it runs superficial to the flexor retinaculum to supply the skin, that is the cutaneous supply, to the thenar eminence. In the distal forearm, about 5 cm proximal to the wrist, it gives off dorsal cutaneous branch which provides a sensory innervation to the skin over the medial third of the dorsum of the hand and medial 1.5 fingers. So medial 1.5 fingers and medial side of the dorsum of the hand it supplies. So that is about the cutaneous branches which are given off in the forearm. And in the palm, the ulnar nerve. So let's see little more in detail. So we can see here is the ulnar nerve. So the ulnar nerve enters the palm by passing superficial to the flexor retinaculum, lying lateral to the pisiform bone. And here you can see like a separate opening called as ulnar tunnel. And here the ulnar nerve is covered by a facial band called as volar carpal ligament, and the space under the facial band is termed as ulnar tunnel. So you can see like a separate tunnel. So that is about the ulnar tunnel where it enters into the palm. And just distal to the pisiform, the ulnar nerve divides into its terminal, superficial and deep branches. The superficial terminal branch supplies palmaris brevis, provides the sensory innervation to the skin on the palmar surface of medial 1.5 fingers. So it provides surface to 1.5. So 1, you can see this is by ulnar nerve and this also. So medial 1.5 fingers. So that is about the cutaneous supply. And the deep terminal branch enters a canal called as Guyon's canal, which is also called piso-hamate canal, canal between the pisiform bone and hamate under the cover of pisohamate ligament, and turns laterally into concavity. You can see it turns laterally into its concavity in this way. Within it turns laterally concavity within the deep palmar arterial arch and ends within the substance of adductor pollicis which it supplies. So the deep branch of ulnar nerve is purely motor and supplies all the intrinsic muscles of the hand except the muscles of thenar eminence and first two lumbricals. Rest of the muscles in the hand are supplied by the ulnar nerve. Let's see the clinical aspects of ulnar nerve. Injuries of ulnar nerve is very common at two sites. One is at the site of elbow. We know that it is related to medial epicondyle of humerus, and next site is at the wrist. So injuries of ulnar nerve at elbow may occur due to the fracture, dislocation of medial epicondyle and thickening of the fibrous root of cubital tunnel. So we were discussing here, this is cubital tunnel which is present posterior to the medial epicondyle of humerus. So the injury of the ulnar nerve it is because of the thickening. So the compression, this thickening. So this fibrous band, this get thickened and compresses the ulnar nerve. That is the entrapment of ulnar nerve. And the other reason is the fracture or dislocation of this medial epicondyle. So the entrapment of ulnar nerve is called in the cubital tunnel is called as cubital tunnel syndrome. Compression between the two heads of flexor carpi ulnaris. We know that ulnar nerve and as soon as it enters into the forearm, it enters into the between the two heads of flexor carpi ulnaris muscle. So it can get compressed between these two heads. Next is valgus deformity. It is also called as tardy or late ulnar palsy. So valgus means lateral deviation of the elbow is called as valgus deformity. And all these causes ulnar nerve compression at elbow, resulting some characteristic features like atrophy or flattening of hypothenar eminence. So this hypothenar eminence, it gets flattened and there will be partial claw hand. So affecting the ring finger and the little finger. These two fingers will be completely claw like this and other may be partially. So this is called partially claw hand, and the first phalanges of these digits are extended and the middle and the distal phalanges will be flexed. So the first will be extended like this and middle and the distal phalanx will be flexed. Loss of abduction and adduction of fingers also occurs, and flattening of hypothenar eminence and depression of interosseous spaces on dorsum of the hand due to atrophy of interosseous muscles, and loss of adduction of the thumb. So the adductor pollicis is supplied by ulnar nerve. So there will be loss of adduction of the thumb and loss of sensation over the palmar and dorsal surface of the medial third of the hand and medial 1.5 fingers. And the test which is positive for ulnar nerve is called as Foreman's test. So what is this Foreman's test? When the patient is asked to make a strong pinch between the thumb and the index finger, the grip and the flat, gripping a flat object like holding a paper or a thin strip-like object, and such that like a piece of paper between the thumb and the index finger. The examiner then attempts to pull the paper out of the subject's hand. So in ulnar palsy, due to the weakness of adductor pollicis, which would keep the interphalangeal joint straight, and the flexor carpi longus muscle will be substitute adduction action. So because of that, the paper comes out very easily like this. So he can't have a proper grip. So this test is called as Foreman's sign or Foreman's test. So it is positive in this. Next, injury to the ulnar nerve at wrist. The ulnar nerve at wrist is injured due to superficial position of the ulnar nerve. We know that it lies superficial to flexor retinaculum. So as it is superficial, it is the site which makes it vulnerable to cuts and wounds and any suicidal attempts. And compression of the ulnar nerve in Guyon's canal, that is at the 𝗑𝐻𝐽𝐻 canal also it can occur. So let's see the characteristic features of these conditions. So the characteristic features, foremost important thing is the claw hand deformity, which is affecting mainly the little and the ring finger, and this it is more pronounced because flexor digitorum profundus is not paralyzed here. So therefore there is a marked flexion at distal interphalangeal joints. So that is the reason of more pronounced ulnar paradox. Then atrophy and flattening of hypothenar eminence. So this hypothenar eminence won't be prominent and it becomes atrophy. And loss of abduction and adduction of fingers because intraossei muscles are lost here. So palmar intraossei muscles, and so abduction and adduction is lost. And already we discussed about Foreman sign, which is positive. So Foreman sign is positive in ulnar nerve palsy. So this completes the clinical correlation of ulnar nerve. So I hope I completed the basic anatomy of ulnar nerve. Thank you.